Welcome to a very special edition of the Wempower podcast. My name is Rebecca Crockett, and as part of Wempower's month-long series on medical misogyny, I'll be speaking to the people fighting to end the gender health gap. This week, I'll be speaking to Simphiwe Sansani, a medical educator and nurse consultant in sexual and reproductive health. She's also the founder and CEO of Black Nurses and Midwives UK, a community of professionals and students committed to sharing their experiences as well as empowering others. Today, we'll be talking about health inequalities for Black women in the UK, as well as how we can achieve health equity. Okay, hello Simphiwe. It is lovely to have you on the Wempower podcast. Just to get us started, if you could give a quick introduction to yourself and your work.
Thank you so much, and thank you for inviting me on. So I'm Simphiwe, and I am a medical educator within the pharmaceutical world, particularly in women's health. I've also had a background in sexual and reproductive health, and I basically love getting involved in anything to do with women's health. So I sit on various committees to do with health inequalities, for instance, or sexual and reproductive health, and that's me in a nutshell.
It's great to have you on, but just to sort of talk about a lot of your other work, you are the founder of Black Nurses and Midwives UK,
I
which
am
is
indeed.
an amazing thing. It's such a big thing, but yeah, so what is it and how did you get involved or how did you start it?
Yeah, no, thank you for asking me. I mean, I should have really mentioned that in my intro. So yeah, Black Nurses and Midwives UK was founded in the midst of the pandemic. Basically, we were being obviously redeployed to various settings. Most health professionals were being redeployed to various settings. So I started connecting with other Black nurses, midwives, students, just because a lot of us felt that we were being redeployed to settings that we weren't familiar with, our opinions we didn't feel we had a say in terms of where we're being really deployed. So, for instance, I was working in sexual and reproductive health at the time, and they wanted us to go back into acute care and working in places like in ITU, for instance. And I just felt like I don't have the skills to work in acute care. And through connecting with various people, a lot of people felt the same. And actually, during pandemic, obviously we all thought the same thing was happening, but I think what started to become more apparent is that unfortunately Black people and other Asian or ethnic minorities were being redeployed to more high risk settings. And basically we started connecting with a few professionals, and that's how it came about really. And over the years, I thought it'd be just a pandemic baby, but it's continued to thrive. So we've continued to now, support events and in various sort of supporting career development or talking about health inequalities, talking about development within your role if you want to become a senior nurse. And yeah, so we've definitely enjoyed connecting as a group, and it was just a safe community, really, a safe space for us to voice our concerns and not feeling judged and feeling like we're getting support and you could openly discuss any of concerns that you were having within that group. So I feel like it continues to be that, but we are also collaborating with other organizations, which is exciting as well.
Yeah. And I think what's so special about your group is the fact it's a mix of professionals who've been there for years and also students. And I'm sure a lot of people can identify with that feeling of wanting a mentor. And I'm sure a lot of people have maybe stuck it out in the healthcare
Oh,
system because of
completely.
that mentor. Yeah,
Yeah,
definitely. So,
yeah.
and
Oh,
like it's
definitely.
yeah, yeah. How do you feel about that? Like, is that a source of pride for you that you've been that um sort of that community for those people?
Yeah, no, it's definitely something I'm proud of. I think the th key thing for me is I've also gone into an area which I feel like is a bit of a niche. So sexual and reproductive health, not a lot of nurses come out of nursing thinking that's exactly where I want to work. But I actually completely enjoy my job. And now I spend a lot of time also talking about the fact that as a newly qualified or as a student, you can actually go into this field because I think we're kind of lulled into the false forced, like, as in you have to go into acute care, to be a good nurse, you have to work in certain settings. So it's been nice to sort of share my journey and my career path, but also to connect with other senior nurses who have loved working in acute care and actually can also, mentor nurses and students and midwives within the organization as well. And we connect with people from various different walks of life. So we actually have a directorate of various professionals, and you can basically be paired with an individual. So if you are interested in a certain field, you can be paired with that individual as well. So it's a bit like a mentor, really, for them to guide you. You can ask them questions about their role. How did they get there? Can support you with interview prep and things like that. So it's very satisfying, which is why I've probably kept it on.
Yeah, definitely. And like I'm sure there's probably benefits for patients as well, because obviously if people like if Black women are feeling empowered within the industry, they're going to stay longer, and that means that sort of patients are going to see people in the industry that look like them.
Oh,
And so,
oh,
yeah.
definitely. Representation matters, and we can't emphasize that enough. We know that, even currently within the NHS, there's poor representation within senior leadership for Black and sort of Asian and other ethnic minority people. So representation matters, and I think it's something that we really do need to harness a bit better. I mean, we are taking positive strides. The NHS is very, mindful in different settings, is mindful of having nurses from various backgrounds, but we're still, it's still baby steps, we still have far to go. But I think even thinking about literature, for instance, literature tends to have white women, and not have colored women on the literature, but I think we're doing so much better. And
Mhm.
even now animations can be brown rather than being sort of white. So I think, yeah, we're definitely taking the, positive strides forward.
Yeah. And so when I was sort of uh, again, looking at the literature, like reading around the subject, I saw this word come up quite a lot, or phrase, cultural competence. And
Yeah,
I hadn't really thought about it before, or I hadn't really put a name to it. And I
yeah.
wondered if that's something that Black nurses and midwives talk about a lot, and whether if you could sort of talk me through it personally about what it is and what it looks
Yeah.
like for you, sort of.
Yeah, no, I guess, yeah, we've not really spoken about it within the
Mhm.
organization so much, but I guess probably in this summit, because it's about health inequality specifically, it will probably come up a lot. But basically, cultural competence is it's a way of communicating with various communities. So it's being able to communicate, because obviously there are different ways to communicate with different communities. And I think, it's not only about the language, it's also about the actions. Different actions mean different things to different cultures. So it's all about that understanding element. And I think it's really important because we are such a diverse, the UK is very
Mhm.
diverse.
Yeah.
So it's important that actually we understand these various culture, religions to be able to communicate with those individuals, because somebody might refuse a certain procedure, but it
Mhm.
might be that they don't understand how it benefits them. But also we need to be able to say, oh, actually, ask them in an appropriate, respectful way, why do you not want this particular procedure? Because it might be religious why they don't want it.
Mhm.
And I think that's very important. So for instance, Jehovah Witnesses, they
Mhm.
don't receive blood. It's important to know what cultures or religious backgrounds people are from, because this can influence their health. So yeah, it's definitely an important aspect of care.
Yeah. And it's listening at the end of the day, which yeah, like, and I think that's an issue we see throughout women's health. Um yeah, and I don't know, is that frustrating to you when it's this small thing that we
We're
see, it's a
getting wrong.
stumbling block. Yeah, it's again and again we just see it, a lack of
Yeah.
listening.
It
Yeah.
is. Oh, it's super frustrating because actually communication is the basics of everything in life. And we're still getting it very wrong. And I think for Black women, there's another layer due to
Mhm.
other factors, including racism within healthcare, that yeah, we're just not getting it right. And I think for me, because my passion is women's health, we need like an for me, I feel like we need an uproar from the roots. And literally, there's some deep digging we need to do to just really turn it on its head because we're honestly, it feels like we're taking more steps backwards than we are forward at times. So yeah, super frustrating.
Yeah. Is there any well I was gonna say for anyone that doesn't know, I think the statistic that Black women are 4 times more likely to die in pregnancy and childbirth, it gets thrown about quite a lot, and
Mm,
rightly so, because it is shocking.
yeah.
But I wanted to ask, like obviously we've said there that a lack of listening within the healthcare system is very prevalent.
hmm
But where do you think in the healthcare system that we're failing Black women specifically? Is there certain unique issues that are leading to these statistics?
So I think it's definitely multifactorial, and I think there's definitely multiple layers of what's going wrong. And I think, yeah, the listening is definitely one element of it, the communication. So I think when you present to a service, there's always an assumption about Black women. So I can, for instance, give my personal experiences. I've been through the maternity services twice. First time, unfortunately, was very poorly, and my baby was very poorly and have sepsis actually, which can be fatal. And it's that whole thing that despite advocating, because I think a lot of the time there's also this thing that we need to advocate for ourselves, but at the same time, I'm a person who could advocate for myself. I have a mom who's a nurse and a midwife and was continually advocating for myself, but we still weren't taken seriously. We weren't listened to. I was spiking temperatures of 40 that they couldn't control. And despite all of that, my waters had broken. Like I could tell you, like honestly, a whole string of things. But each time we kept voicing our concerns, we basically weren't dismissed. I think at a point in time where I was deteriorating even more, my mom had escalated about, like what's going on? Are we, going to deliver the baby as well? But nothing happened until my baby's heartbeat crashed. And then it was obviously much more of an emergency then. So I think there is definitely a lot of things, but the key thing is that we're just not taken seriously. So even with things like pain, there's an assumption that Black women are strong and can endure a lot of pain. So when we ask for painkillers, we're generally not given them. Or we're not counseled properly around our options. I mean, we could spend literally the whole day about some of the issues that exist.
Hmm. Yeah, I know, and that question is so general, and I'm so sorry that happened to you because it's yeah, it's more common than sadly like it
It
should
is.
be. Yeah.
Yeah, it totally is. And I think sometimes when I talk about my experience, people think you working in healthcare, you're almost immune to it. And it's like, no, you actually are not, because at the end of the day, when I present, I'm still a Black woman,
Hmm.
and I'm still treated the same as any other Black woman, despite, anything else. So even if you are able to, talk the medical lingo, which I think sometimes that's what happens if you don't understand the lingo. It's like there's almost this foreign language that's, unraveling and you can't understand what people are saying to you. But you could understand the lingo and you're still, not treated any different. So I think that's definitely the key thing. And I think, yeah, just respecting individuals,
Hmm.
respecting people, not being having prejudices and prejudgments, because I think another stereotype is that Black women are angry, and we're really not. But yeah, we're put often in situations where we are having to really advocate for ourselves, and then it comes across like we're angry and we're this, but it's if you treated me kindly and with respect, I wouldn't have to be this person that I'm having to be just to
Hmm.
have basic care, which sometimes does feel like it's, a bit, yeah, very frustrating. But hey,
Yeah, of course. And
mm,
like it's not fair, and it's a failure of the system, but women are being forced to advocate for themselves constantly, and
yeah.
it's not fair, and I hate to ask it, but like do you have any advice for somebody that has to do that? Like as you said, you were somebody that had a lot of backup from your mom. you yourself knew what you were chatting about, but for people
Mm,
that might be a bit hesitant to do that when they're sadly put in those situations, I don't know if you have any advice
yeah,
for them.
no, definitely. And I think the key thing is that one, I think it's not on the women to advocate for themselves. We go
Mhm,
into healthcare to be carers, to help people. And I think, it's really sad that we're getting to that point where we are now giving it back to the women and really making the onus on the women. And it's actually our responsibility because we should be there. We should be the first advocate for that woman. So it's really sad that we're having to even discuss this.
mhm,
But yeah, it's that's the first and foremost thing that I would say. But I think always don't be afraid to express for yourself. Nobody knows your body better than you. And I say this even within, sexual health settings where you're having an examination, if you're feeling like that you're being dismissed, nobody knows your body better than you. Always ask for a second opinion, and you have the right to ask for a second opinion in various settings. So if you're not happy with that, how that appointment outcome has gone, ask for another person. So even with, you know, the hospital, for instance, if you've seen one doctor in maternity, you can ask to be, change and transfer to another doctor. So always ask for, a second opinion. Hopefully it doesn't get to third and fourth, but if it does, you know, you may have to do that at times. It's something I hear all the time where, especially with things like endometriosis, which is a condition where uterine lining is growing outside the uterus, which can be found in other places like the pelvis, even the heart, it's been found,
mhm,
the lungs, people generally have heavy, painful periods. It can take up to 9 years for you to get a diagnosis. And often these people have been, dismissed for years, saying it's a normal period, but it's not normal to have that kind of period. So yeah, it's also knowing that, yeah, ask
mhm,
for multiple opinions, ask to be to refer to different settings, note down things. So when you go to an appointment, write everything that's been discussed so that you know and you're clear in terms of the plan that's being discussed as well. Take somebody with you. That's always a good
mhm,
way, especially if you're nervous, because then you can lose your trend of thought. So having that other person with you is always good. And also noting down what you want to discuss at the appointment. And if you've got somebody there, at least they know, you've told them exactly what you want to discuss. That's all the key things that you should do. But it's really sad that we're having that conversation. But unfortunately, you do need to be equipped because, again, you've got 10 minutes. I don't know what women can discuss their problems in 10 minutes. We always have more than one issue. So
yeah,
10 minutes in a GP practice, you need to be to the
yeah.
point. You know what I mean?
I mean, I've had that thing where you're something might be wrong with you and you're like, oh, I don't really know if I should go. I don't want to be a burden. And it's almost like things just keep piling up, piling up.
Mm,
And I used to call it my MOT. Like I would go in and I'd say, okay, I need to talk about
yeah,
this, and this. And it's like, it shouldn't be that way,
it
but
shouldn't.
you have this shame around it and you just feel like a burden. But people really need to know they're not a burden. Like it's their body,
Oh, yeah,
you know?
definitely. Yeah, no, I agree. And I think go in,
Yeah.
and I think the more you go in, you sort of normalize the whole going in and having that conversation. I know
Mhm.
it's not a natural sort of process because a lot of us, yeah, do, definitely don't want to seem like a bother. And I think for Black women, it's even worse. There's
Yeah.
another added layer because there's a lack of trust within the health system. So for them, it will take even longer. So even cancer diagnosis, we know that they would have had early indicators, but not necessarily follow up until it's sort of escalated.
Mhm.
So yeah, definitely go in and normalize sort of going in. If there's any concern, go when it first occurs, because definitely if there is anything, it's always better for us to find it earlier rather than later.
Mhm.
And remember that GP, yes, they are your first port of call, but generally there are other settings you can go to as well. So, for instance, sexual and reproductive health generally can also help, especially if
Mhm.
it's things to do with like periods or discharge or, um, yeah, discharge and penile discharge or anything like that. Then definitely you can go to those settings. Conception, again, they're more accessible. Even pharmacy now, a lot of pharmacy do testing and do conception. So yeah, there's definitely other places. And then hopefully within the next sort of months to years. We'll also have the women health hubs, which will definitely alleviate a lot of the waiting times for GP because we know that they're snowed under. They're not like just, sitting there. They
Yeah.
definitely are snowed. But at the same time, I don't want that to deter people from going in. If you need to see a health professional, book in, do not wait.
Yeah, definitely. Um,
Yeah.
I wanted to turn quickly to sort of postnatal, after pregnancy, sort
Mm,
of the things that you need to be checking then. And I think one of those things is contraception, obviously.
yeah.
And I saw a statistic where Black women aged between 15 and 49 are way less likely to seek or have contraception. I
hmm
just wondered your thoughts on that, what you would like to see change to sort of open the conversation up a bit more and yeah, like sort of have that conversation around contraception because I didn't realize the numbers were so low.
Yeah. So I think with contraception just generally there's also it's multifactorial. There is a
Yeah, of
lot
course.
going on.
Sorry.
Yeah.
I realize when I say this, I'm asking you very general questions, but there's so much that's going into it. So I
There is.
apologize for that. But
Oh
yeah,
no, it's absolutely fine. So yeah, it's
yeah.
definitely multifactorial, but I think one of the key things with contraception at the moment is access to contraception is
Mhm,
really hard. Some years ago, it was super easy. You could get an appointment in no time and you could get your method of choice. Whereas now there is definitely a reduction in, contraception services, sexual health services. So you're not able to get it as easily. Before you could just go in somewhere and, wait and you'll be seen. Whereas since pandemic, a lot of services don't even do walk-in anymore. So you have to have a booked appointment, which I think definitely could influence what people will go on. I also think when it comes to the background of contraception, so there's
mhm,
a lot of contraception that was actually tested on Black and ethnic minority people, and I think people don't realize that this history, there's a lot of people who know about it, and I think it still does influence contraception uptake today.
yeah.
I don't think that every single person who's not choosing not to do use contraception who's Black, it's because of that, but there is definitely that aspect that what am I putting in my body? Is it actually fine for my body? There's also a lot of myths, I think, generally that exist, not only for Black women, but other ethnicities as well. So there's concerns around hormones and the effects and mental health and fertility. I mean, the list goes on, but
Mhm,
there's definitely a lot. And I know at the moment we have a lot of women who are moving off hormones
mhm,
due to mental health and other factors. And even things like natural cycles is on the rise. And lots of people do use natural cycles, but again, because it requires you to input so much information, we're not that way inclined, to record your temperature every day, your type of discharge, and your cycle. We just find things that are like that too tedious, and I think we're not very good at following it, regimental. And often women do fall pregnant
mhm,
using natural cycles. But it can be very effective if it's followed correctly. But I think a lot of people don't. And I just think contraception counseling, it goes back to that communication piece
yeah.
again. There's in healthcare, there's sometimes this negative aspect when Black women present to services. So the way you are counseled or told or communicated about the different methods is not very in a, supportive manner.
Mhm,
And then often women leave the service with nothing because, it feels like you're pushing a certain method. And I think for a long time, we were also pushing things known as LARC, so long-acting reversible methods, which is your implant, your coils.
mhm,
The injection is debatable whether it is a LARC or not, but then women might not want things inside of them, and
mhm,
then if you go to an appointment and the nurse is saying, no, you should take this, it's not going to make you want to have something because they're not really considering what your wants and desires are. So I think that probably needs to change. And actually, Reproductive Justice Initiative, BPAS, and another organization did a survey, I think it was 2021, and that survey revealed that actually women of color felt coerced into specific methods, especially LARC methods, and they felt that their contraception appointments weren't supportive to their needs. So I think that still goes on today,
mhm. Yeah.
definitely. Yeah.
it goes back to what you said about just the lack of trust. And
Mm,
yeah, it's I how do you even build up that trust? Because it's not over the last decades, it's as you say, it's from the beginning of the pill, right
mm,
from when they were testing it.
yeah.
Um it feels impossible. Like I don't know. And like people obviously there has been things that try set up to try and sort of combat that
Hmm.
mistrust, like the maternal disparities task force. I mean,
Yeah.
but then again, there's sort of you get something and then it's taken away. Like it was set up in 2022 and all these things were sort of promised, but then they didn't come about. I don't know. How do you feel about that task force? Have you discussed it much with your colleagues? Like, do you feel
Yeah.
like doing much?
The thing is, I think the problem is that I think for years now, we're very good at setting up task committees, boards. We're very good at that. We're very good at meeting and talking, but we're not very good at actually making it happen. And I think, again, when I think about research, again, they say, oh, research is really poor in Black and ethnic minority. And the reason why sometimes people don't want to participate is because, fine, yes, you might say you have representation of Black and ethnic, but we're not seeing any change. We're very good at talking, but we're not seeing the change. We're still seeing, I mean, why is it that we're still, it's only moved from 5 times more likely to die in childbirth and postnatal period to, well, it's 3.7 now. Um, but it's still, why does that even exist? And why are we having to talk about cultural competence and equality and diversity? Like, because there's so many ongoing issues. And this is not now. I mean, if we think about history, Martin Luther King, and there's so many historians who've been doing this for so long, you know. And I'm not going to discredit what the work that's going on at the moment. I do think it's fantastic, and we still need to continue to talk. But we're just the talking is enough. We need actions. We need more actions.
No, of course. I mean, that brings me quite nicely to a question I'm asking a lot of people, and it's
Mm.
if you had a magic wand and you could change something tomorrow about the healthcare system, what would be that change you would want to see?
I think for me, it's just equity in health, whether you're blue, pink, or green, for you to present to a service and you feel heard, you feel respected, you feel supported, is key because I, I, I don't even feel safe, at times within the healthcare system. I'm having to question certain things that happen. And it's really sad because I work in healthcare and, you should feel, but I don't. And, I'm a person who has the knowledge working within that health system, whereas I even feel more scared for people who don't. So with family and stuff, it's like sometimes I will, I'm happy to, give them a slight like consultation, be like, okay, you need to discuss this with with your doctor, because if you don't, then who's giving support to those people who don't have family members who work in healthcare?
Hmm.
It's a bit of a scary world, really.
Hmm. Yeah, and like you mentioned earlier about the Health Equity Summit that Black
Mm,
Nurses and Midwives was part of. I'd love to hear more about that because it sounded like it just sounded amazing. So yeah, if
yeah.
you would, yeah, it's just.
No, that's fine. So yes, on the 26th of April 2025, we're having the Health Equity Summit, and we've chose key topics that are close to my heart and affect mainly Black people, but Asian and other minority groups as well. So the topics we're focusing on will be menopause, because we know that there's quite a lot of disparities around menopause care. So we're less likely to be on HRT, for instance. We're disproportionately affected by things like diabetes, high blood pressure, and cardiology. So that's also part of the topics we'll be discussing, and just trying to bring in the patient voice as well throughout those topics, and as well Black maternal health, just because not only my personal experience, but I think it's an important topic for us to explore because of all the things that are happening currently. And actually, there are so many touch points that the nurses that I work with, they might be caring for some of these women. And actually, how can we support them? How can we be those advocates for them? Because like I said earlier, I think we're pushing onus on women to be their advocates, but actually, as professionals, I think we should be the first advocate for those women, really supporting them and them to feel trust in us.
Mhm. Well, thank you so much. I just want to say, like, you are one of the people that are doing that. You're not just talking about it. I think a lot of people watching this will see that. So thank you so much. And if anyone wants to find you and find the work that you do, where can they find you online?
Awesome. Well, thank you so much for having me. So, I am on LinkedIn as Simphiwe Sansani, but we do have a Black Nurses and Midwives UK page on there. We're also on TikTok and Instagram, and you can also find us on our website, which is also Black Nurses and Midwives UK. Thank you so much.
Thanks for listening to the Wempower podcast. To find out more, visit our website wempower.co or follow us on socials at Wempower UK on Instagram and TikTok, Wempower on Facebook, and Wempower UK again on LinkedIn.